Thank you very much for coming.
Thank you, Miguel. Thank you, Manos and Manos, for inviting me for this lecture. It's the first time I come to this course, and it's very impressive. You have amazing faculty and very interactive sessions, so I really appreciate to be here, and I hope that after the lecture, this one, you will accept me to come back. Manos told me, I like the way you are thinking, I like the way you are a little bit disruptive comparing to the other surgeons. So today I make a lecture which is a little bit probably different of what you are waiting for. You all know that the aim of the surgery that we are doing is to try to improve the function, to decrease the pain of the patient, and to create healing. And we think that if we do that, we can prevent degradation and restore the anatomy. So when you go to the literature regarding what is the future of the cuff repair, the first thing you are thinking about is biology. And we have Miguel here, who is the expert. And if you want me to speak about biology, probably I will come back to my early experience when I did a PhD about stem cell and all that stuff. And we know that now that since 20 years, we have many people who are speaking about scaffold, cells, and bioactive molecule or whatever, and even bioactive membrane now, and we have a wonderful work from Miguel showing that there should be an interest. But with the few small experience that I have since 20 years, every couple of years we have a new wonderful patch that is issued by the company and demonstrate a wonderful power, and 2 or 3 years after we forget it. So I will not discuss about this biology, but about our topic. The other topic that I love is sustainable surgery, which is very, very interesting. How can we improve the quality of our patient without spending much money and much waste regarding the global warming? So it's very interesting, but I think sometimes it's not exactly the topic that we should have today, because with this sustainable surgery, there's something that we think about is why do we do this kind of surgery? So we have this morning some highlight about the natural history of the rotator cuff. We need to understand what the patient is complaining about, and we need to understand what is the cause of pain, because 99% of the patients who came to our clinics, they complain about pain, not necessarily about weakness, but pain, and we say, okay, we're going to treat the pain with surgery. And we need to come back also to the basic, what was the history of full tear rotator cuff repair to understand what we are doing today. So I will try to go forward and to see exactly what happened when you repair the cuff. Do patients improve? Do they improve better when you have a healing? Do they improve better than physiotherapy? And what is the next of the future of full thickness tear rotator cuff repair? So when we go to the natural history of rotator cuff, you all know that there is many factors. We imagine there is many factors, but basically we don't know a lot of things. We have patients who have cuff tear, other ones who don't have, and we don't know exactly what is the cause. There is many factors. We know that the rotator cuff tear affects many people, almost 40% of the people who are older than 60 years old, which means that for us, shoulder surgeons, it will bring us a lot of cuff repair. The prevalence of asymptomatic partial thickness tear is high also, of around 40%, and most of the full thickness tear are asymptomatic. In the literature, we see between 0 and 46%, but when you see to other papers for younger people, we can see that there can be much more asymptomatic. If we imagine that we have 40% of our population who has cuff tear, we do not operate on them. And we know that chronic reconstructive can become from asymptomatic to symptomatic, but also that symptomatic can become asymptomatic. We all have the experience that we schedule some people from the shoulder cuff repair before the COVID, and 2 years after, they do not need any more surgery because they were perfectly okay. And even if asymptomatic rotator cuff can become symptomatic, sometimes they don't do, and we don't know why. We know that rotator cuff is just related to the age. And this study from Boston demonstrates that when you are basically 100 years old, you always have a cuff repair. And for people who are 50 years old, it's around 40%. But after 70, you have basically 45% of the people who are with a cuff tear. In the population we treat, most of the papers about cuff tear are for people who are 60 years old. You have 1/3 of the patients who have a cuff tear around this age, which means that having a cuff tear at 60 years old is normal. It's physiologic. It's not a disease. And when you see the symptoms, you see that, of course, when you are young, you have basically 20% of the population which is symptomatic. But the getting older, the less the symptoms appears, and most of the people after 70 years old have no symptoms. So can we change from symptomatic to asymptomatic? We, as surgeons, we have many information. We know that this full thickness tear will not heal without surgery. We are sure about that. We know from many papers that there will be a progression of the tear on over time, mostly depending on the age, on the size of the tear, on the fat infiltration. There's a high risk of becoming something which is a destruction of the joint. We know that the medium-sized tear on smoker have quickly a progress of the degradation. And from the paper of Karl, of a colleague from Germany, Karl Weser, we know that 8 years after you discover a cuff tear, probably it will be not possible to fix it, and you will have an early sign of osteoarthritis, which makes us thinking that we need to fix it. But basically, when the patient comes, what is he complaining about? He's complaining about pain, limited range of motion that can be active or passive, depending if there is any stiffness or not, and weakness. And what happened? Well, you see something abnormal, or it's supposed to be abnormal on the anatomy. It is what happened many years ago. You know, everyone knows that Charles Neer said that probably there is some kind of impingement. And there is an impingement because the acromion is aggressive. And he developed, and we still use it on the physiotherapist a lot because they ask to the patient to try to increase the space below the acromion to prevent impingement. So this is a very simple idea that makes us think that probably the acromion was the cause of all the pain of the shoulder. I let you see this very small video that you can find on the web by Per Aspenberg, as I don't know, which is professor of orthopedic in Sweden. I don't know if he's here, but it is this very simple about myth busting in medicine. And he explains you that as orthopedic surgeon, we want to have things very simple. We know, for example, and it's the inductive thinking, that the joint surface has no nerve. We know that the meniscus knee has nerve, and the pain at the knee should come from the meniscus. Then, because it is very inductive, you can make a deduction. If you remove the meniscus, you will have no pain. And all the practice that we have today is based basically on this kind of rationate. We know now that when you have something which is an inductive thinking, we will do a lot of science about that. And there is many papers that have been published about the vascularization, the innervation of the meniscus, about what happened when the meniscus is abnormal. And we have the same thing that was published about the acromion. Do you remember? We have this paper from the classification of the shape of the acromion, and everybody was thinking that there was an impingement. And we just spoke about the impingement this morning. And we had this very simple idea. Acromion is aggressive. There's an impingement. So we make a lot of science around that. And for us, surgeons, it's very reassuring to know that. And the deduction is we need to remove it. If we remove it, it's very simple. There's a lot of possibility to make science, and we will improve the quality of the patient. And I remember when I was going to the French Society of Arthroscopy meeting 15 years ago, we have basically half of the communication about the shoulder, about do you remove 1 millimeter, 3 millimeter, 5 millimeter, do you remove lateral and medial, and there was fighting about what is the best solution. We know that if we do that, it will improve. And it was very interesting that the concept was renewed by the paper of Hellman that said we can do it under arthroscopy. He described exactly the technical procedure. So if there is a technical procedure, it means that it works, and we need to keep it in mind. But there's one element that destroys every myth, is the studies. So when you go to the literature, at the beginning, we were thinking that subacromial decompression should be efficient for tendinopathy because we have an impingement. You can treat this impingement syndrome with acromioplasty. We can prevent the cuff tear because there's no thing which is aggressive now with the tendon. And mostly also we can imagine that we can improve the cuff repair and probably the retear after a cuff repair. So you go to the paper and you see that at 1 year, 2 years, 5 years, 10 years, when you make a prospective randomized study comparing the result of subacromial decompression in tendinopathy, nothing happened. So it doesn't work. And the other thing is that you can say for the cuff repair it works, but you go to the literature, you have prospective randomized study that says that when you do a subacromial decompression or you don't, there's absolutely no difference. So now you know that there's no effect of the acromion. Of course, we are happy. We have a new choice to play with, which is the critical shoulder angle that has been described by our master Christian Gerber, so we think it's efficient. But there is more and more literature saying that probably there's no correlation. And what is very surprising is even if we know that there's no reason to do an acromioplasty, when you go to what is done in the clinical practice, you see that from this review of the American data, that from 10 years period, they just decreased the number of acromioplasty of 10%. It was statistically significant, but in most of the cases, in 74% of cases of rotator cuff repair, American surgeons do an acromioplasty. There is several issues, of course, it can help you to see. And of course, there is some element like financial support that can explain that. But even if we know that there's no reason to do it, we still do it. So back to patients. For patients, they have pain, limited range of motion, weakness. They have an acromion, but now we know that it's not responsible of anything. And we discover what? We discover a cuff tear. So what do? We think that the cuff tear is responsible. We know that we can treat the patient with painkiller, injection, rehabilitation. And most of our colleagues who are rheumatologists or even the physiotherapists, they say that they can have a good functional result without any surgery. But we are surgeons. We do not think that. And we think that probably the cuff is the cause. But most of the patients, with time, they have no more pain. They have no more limitation of the range of motion. And weakness disappears with time. So why? We can try to see from this in the literature to have the answer. Regarding the pain, we have a lot of data from the science, and we love that can explain why we have a tendinopathy and why we have pain. We know that on the left side there is some mechanical, and we like orthopedic surgeons to have this kind of very basic explanation. We have microtrauma, misuse, overuse, trauma. It can be related to the work, which is very important for working composition. And for us, we like to deal with a sports guy with microtrauma related to acute sport. Then on the other side, there are systemic factors like diabetes, hyperlipemia. We know that tobacco, some antibiotics can have an effect on the tendon, but there is age, natural aging, and also there is some element like the natural evolution of the body that can explain that we have a tendinopathy. And when we go to the symptoms, we have this very interesting study from David Ring that explains us where does the pain come from. We are all very focused on the right side because we are basically biomechanical surgeon, and we know that we can have a pain related to subchondral bone, to the cartilage defect. We know we have inflammation of the synovial and the bursa, and we like to see this beautiful image on the bursa. But there's also two other causes of pain, and most of the patients have neuropathic pain, global pain, and allodynia. And we know also that there is some factors that we probably, in our constant score, in our assess score, or even in many scores, we do not assess. There is a huge prevalence of psychological aspects. Most of the patients, they are very afraid of moving their shoulder. We call it kinesiophobia, and this kinesiophobia is responsible for pain. If you remove it, you decrease the pain. The other thing is that French people from Paris, they say, I don't want to be old. I want to stay very active. I want to play golf even if I am 65. So they're getting depressive. They get depression, they get anxiety, and they are concerned about getting older. And it's part of the pain that we are treating, but I'm sure that we do not take care a lot about that. And for many people, there is also the social impact of the secondary benefit. So you will tell me, yes, of course, it does exist, but it's rare. This is a paper published 10 years ago by the team of J.P. Warner. Those people were scheduled for rotator cuff repair. We imagine that they are normal people, and they just assess what is the mental status of those patients. And 27% of the patients that were ready to go to the OR have a mild to severe depression. And 1 of 4 patients have a severe or mild anxiety, which means that if you treat that, probably the patient will not complain a lot less. And what was very interesting, that this pain and all these elements were not correlated with the fatty infiltration, with the status, or any anatomical element. But you have a worse assess score for those patients, even if it was not correlated to what we consider is the main element of the assess score, the anatomy. There's no correlation. If you see this other paper from the Moon Group, we are very jealous in France because the Moon Group is very efficient. We used to do a multicentric study, but now they are doing a lot of paper. And you see, for example, is 453 patients who were candidates for a full 6 rotator cuff repair. And they assess also the depression. And you see that when you have very high pain, it's mostly because you have a bad work evaluation emotion, which means that there is a correlation between the psychological status of the patient and the pain. And they come to you because they want you to remove the pain in most of the case. On the other table, on the right side, you see that if you are a full-time worker, if you are retired, if you have no stress, if you have a good education, probably you will have less depression than the other one. So we must consider that. So you will tell me, okay, you are a stressed Parisian guy, and 25% of your patients are stressful, but it doesn't mean anything. It means something because this other paper demonstrates that when you have a depression before the surgery, your assess score on your post-operative pain is higher. So the status of the patient before the surgery is impacting your clinical result on the global function of your patient. Now you will tell me, okay, we can manage the pain, we'll stop to operate on people who are depressive, who have anxiety, but me, when I fix back my tendon, I have a better strength, and I have less limited range of motion. So we need to speak a little bit about what do the physiotherapists. The first thing we need to know, and it's very important, is that there is currently no paper in the literature demonstrating that physiotherapy works. If you take the patient and you do physiotherapy, or if you do nothing, we don't know what happened. So I know that the rheumatologists, at least in France, they don't send people to the rheumatologist when they have pain of the shoulder because they say that there are no proof, but it's true. Never it has been done to just follow the patient without anything. And the same thing, it was just for the supracromial pain, but even for the cuff, there's no papers trying to see if when you have someone who comes to your clinic with pain on the shoulder and have a cuff tear, if you do nothing, even physio, the people will just recover. There is this very interesting paper from the English writer with a prospective randomized study to see what happened for people who have subacromial pain. So they divide the group in four groups who are equivalent, and they have basically the same symptom before. You have the first group who have just physiotherapy, the first who have almost 12 time. The second group, they have just a best practice advice, which is only one clinic, once during 1 year, to explain them what they have to do. And the third group, they have physiotherapy and injection. And the last one, they have a best practice advice on injection. It's a mistake. At 12 months, all the patients are the same. We miss one group of people with nothing, but probably it's not ethical, but you see that whatever you do, people will improve with time. Now you can say, okay, it's stupid because what is important is the time. So it is a prospective randomized study. For acute, we said this morning, when it's acute, you need to fix it because the results are better. Okay, we have all the feeling that if you operate fresh, torn tendon, it works better. But in this prospective randomized study for people who have acute tear, they operate on one, and they operate on, do not on the other one. It's true, if you do not operate, you have an increasing of the size of the tear in 1/3 of the patient. But at 1 year, the strength is the same, the pain is the same, and the global function is the same. The constant score is better if you operate, but only 4 points. It's statistically significant, but 4 points is not clinically relevant for the patient. So we can say, okay, when it's a massive tear, I need to fix it. You know, we have this wonderful paper from Philippe Collin and Walsh, which is very, very interesting about massive cuff tear. And they say that you can have different types. And when you have type B, which means you have no more subscap and no more supra, there are 0%, no people can recover with the physiotherapy. So I am very proud to introduce you Miss B, which is one of my patients. She's 82 years old. She has no more subscap, no supraspinatus. And she's going to swim every day. And she has normal motion. She's complaining about pain. I saw her 1 year before, I saw her 1 year after. So, of course, in most of the patients, you can have some problem, but with physiotherapy, or for very, very active patients, probably they can do whatever they want. So we don't know why. Some people improve, and I think that the challenge is to understand why those patients can move and others cannot. You can imagine that when you have this kind of imaging, you want to do a reverse, but she's doing perfectly well. We have some paper who demonstrate that when you have neuroperipheral cuff tear, also people can improve. This is a meta-analysis of 10 studies demonstrating that in almost 1/3 to 96% of the patients with a massive cuff tear, you can have a function. We don't know exactly what is the final function, but you can improve significantly the constant score on the assess score just with physiotherapy. So it works. We don't know why, we need to know, but it works. This paper from an author which is just here, was published now 15 years ago, demonstrated that even if you have a pseudo-paralytic shoulder with upper migration of the head, with physiotherapy you can improve. People have no more tendons, they have this kind of upper migration of the humeral head, but doing good physiotherapy program, you can improve the function. And for those patients, most of us will put a reverse. It's exactly what I said. For this kind of patient, I will program it for a reverse, but after 2 years of COVID, they come back, they have no more pain, and they move, and you don't know why. This is another example of the patient who came to my clinic with a massive cuff tear. It's a 60 years old, he's working as a policeman, you know, and I see him 3 months after trauma. So Jean Cani will tell me it's not pseudo-paralytic, you know, because it's acute. But it's acute, but he has no pain, he has no function, and no supra, no infra, and it's traumatic. He has done 3 months of physiotherapy, and I say, okay, probably it's good. I asked him about what he has done, and I changed of physiotherapy. And he came back to my clinics 6 weeks after, you see. Okay, it's not perfect, but he's moving. So we can imagine, I never operate on him because now he's doing well. He has some motion. He's not a heavy worker, and he's happy with that. So you will tell me, so why do we operate on? Well, we are doctors. We have patients who are complaining with us. We want to improve the quality of life of our patient. We use our knowledge. We know that we probably need to do it. We use the science, our training, what we have learned. We like to use our hand, and we try to do better every day. And we come back to Per-Aspenberg theory. So we know that the acromion is not aggressive. Surgeon can be aggressive, but not the acromion. So we have many science saying that probably the tendon should be the cause. So there is a tendon tear, so we can fix it because it's responsible of everything. And we have some elements that make us think that we are right. We have a master who say, you know, there are some tears that you cannot fix. So if they said you cannot fix it, it means that probably we can fix the other one. We have many classifications who are very interesting, and of course we have this kind of meeting. So we come, we see this wonderful repair, and after you see the clinical result in the video. So everything makes you think that probably it is efficient, because you see one surgeon, me, I say, okay, that is the result I have 3 months after, so everything is perfect. You need to fix this patient who is really happy now. But is it really the truth? So we'll come to very long follow-up patient, no, not only 2 or 3 years. This is the paper that has been published by the SOFCOT, which is the French Society of Surgery, Orthopedic Surgery. This paper from those patients are from Gilles Walsh, Christian Gerber, and we have 10 years minimum follow-up with MRI. Okay, so almost 300 patients who had rotator cuff repair. When you see what has inside the patient who were operated on, there's absolutely no correlation preoperatively between the pain and the fatty infiltration of the muscle and the tear size, which means that there's no correlation between the complaint of the patient and the preoperative. The tendon is not the guilty part. And at 10 years, when you have the result, you see that there's no correlation between the healing and using Sugaya and the pain. There's some correlation with the constant score and the strength. I will come back to that. But regarding the pain, if your patient comes for pain, you can tell him that 10 years after, if he has no surgery, he will not have a worse pain. So this is the paper that we already spoke about. 10 years after a prospective randomized study comparing the surgery and the physio, we are very happy because the constant score is statistically significant better. The SS score is better. The pain is better. On contrary to what we were thinking, the strength is not better. There's no statistically significant difference. So we can say, okay, it's good, guys. We need to do surgery to improve. But when you go to what is normally clinically significant, all these elements who are statistically significant are under the significance of something which is a benefit for the patient, which means that for the patient, there's no benefit. For the surgeon, with an objective evaluation, it's good, but the patient doesn't feel the difference. So you will tell me, okay, you are a little bit disappointing. Let's go to more paper. So this paper, the first one is from the French Society of Arthroscopy. It is a retrospective study of 188 patients who have a healed cuff. So the cuff has been operated on, and the patient have a perfect cuff on the MRI. They were young patients, 57 years old, you see, supraspinatus with no fatty infiltration on a double row. So basically 80% of the patient we see. And what we see, that the only element which is responsible of a worse result is when you operate on women. We know we have the same element when we go for the reverse. The women who have a reverse have a less functional result. It's not related to the tendon, but to different elements. When you go to this other paper, also from the French Society of Arthroscopy, where they do the prospective study, they operate almost 200 patients, 1 year follow-up with the MRI, supraspinatus distal, we have 94% of healing, and the one who has no healing has no difference in the constant score. I come back to this very famous paper, 10 years follow-up of 300 patients operated, and you see that there is absolutely no correlation between the constant score and the healing that we aim to improve using patch or whatever. At 20 years, yes, you have a significant difference regarding the patient who have no healing, but it's 20 years after. And in this study, which is one of the most longer follow-up, we have a lot of patients who are lost of follow-up. So what can we say? Do we need to fix the curve for the pain? The Cochrane library, which is probably the most serious database that we can have, demonstrates that regarding the pain, we are not so efficient, and there's a little or no improvement of pain when you fix the tendon compared to the surgery. Regarding the constant score, the global objective function, there's low certainly evidence that it makes sense to make surgery to improve the mobility of the patient or even the strength. When you give the quality of life, same thing. If you do not operate on them, they will have exactly the same follow-up. So I am a little bit disappointed, but if you see what is the next for rotator cuff repair, we know that the natural history of the tendon is to tear on age, and we cannot go against that, in fact, if you have a wonderful graal. We know what is the cause of the complaint? Well, you know that we have some kind of dysfunction, and we know that when you do physiotherapy, you can improve. Most of the patients who have a cuff tear are asymptomatic, so the next deal is to find how to transform a symptomatic tear in asymptomatic tear. We can help physio to do that. There's probably magic element that we can do find, but probably we have to make a better way to better analyze the patient. What is the cause of pain? There are multiple, and probably they are not related to the tendon tear, or even the muscular atrophy. The cause of pain is still very complex, and we do not assess it correctly with the constant score or the assess score. What is the history of rotator cuff tear repair? It's inductive thinking. And today, we have an inductive activity saying there is a tear, I fix it, the patient will improve. So now what can we say? Do the patient improve with rotator cuff repair? Yes. Do they heal? Yes. And we try to heal as much as possible. Do they improve better with healing? Absolutely not. We have no proof, even for acute tear or even for young people, that there is a better result when you have a good healing. Do they improve better than physiotherapy? We are not sure, because many patients can improve without surgery. So does it prevent OR? It was a good question, and we say, well, probably if we do that, you will not have a reverse when you will be 15 years. But we know that it can prevent OR, but do we know if this OR will be symptomatic or not? Most of the osteoarthritic shoulders are not symptomatic, so we are not sure that the one we are operating on will be symptomatic if there is a failure. So what is the next for the full tear rotator cuff repair? I think that we need to better understand the complaint on the mechanism. We need to assess the pain correctly. We don't need, I think, artificial intelligence, but just intelligence to stop to operate so many patients and decrease the indication. Thank you.
Thank you very much, Geoffroy. Certainly unexpected. But anyway, are there any questions or issues, comments? Manos.
Okay, just a comment. You are invited for the next for now. We hope that you will be able to come also.
Thank you.
It's a very interesting topic on what we are doing and how we assess results, and how must still be artists and not just technicians. It's very important to be able to see the world from another perspective, and creativity is the way, the ability to see new ways of getting things together. There is this very nice classification saying that when we have an anterosuperior tear, subscapularis, supraspinatus, we expect 80% of the patient to be pseudoparalytic. But 20% of the patients are going to be able to move the arm. And we always say, okay, what we are going to do about the 80%, but we never ask why those 20% can be able to raise the arm. And from this 20%, we can learn a lot of how the shoulder is working, is functioning. And it was very impressive, all this. Thank you again for coming.
Thank you.
Don't know if there's last question, because this is because I said we had plenty of time, then Geoffrey just took his time and now we are late.
Sorry.
Okay. Geoffroy, so according to what you presented, what do you say to your patients when they ask you, why do you want to do surgery to me? So if you have a patient in which, to whom you propose a repair, and you know that probably that patient will be well with a good physical therapy, even if it evolves eventually to an arthritis, they will remain relatively well. What do you say? What's your excuse?
I didn't show you another slide that, which is a paper that has been published also by the Moon Group, and they collect something like, if I remember, 900 people who were candidates for rotator cuff tear, and they propose them physiotherapy, and 20% of them get surgery, okay, and 80% never get surgery with rotator cuff tear. And they ask them, what is the cause you go to surgery? It's not related to the size, it's not related to complaint, not to the constant score, it's just because the people do not trust physiotherapy. So I used to say, in a provocative way, that shoulder cuff repair is anti-aging surgery. Most of the patients who come to you, just like the guy who was presented on the ring, they are active, they want to think active, and they believe that if they have no cuff tear, they have no cuff, they will not be able to be independent, active, or whatever. So if they told me, I want to stay active, I want to have no sequela or whatever, I tell them, okay, you should be a candidate. The other thing is that we need to find how to make them become asymptomatic. And when we will understand exactly, then there will be probably, I'm very disappointed that no more place for surgery. We stop to do meniscectomy, we stop to do appendicectomy, we stop to do acromioplasty routinely because we made mistake. I think that because we are more and more people who are older, we will get surgery, we'll still do instability, reverse or whatever. But regarding the cuff, if there was someone here who is from the government, they will say, why do you do surgery for people who will be okay? So, as I am in private practice and people come and tell me, if I won't tell you the truth, they tell me, I want you to fix it. Okay, today, if I fix it, you will be better, you will heal, you will have good function. If they ask me what I do if I do nothing, I tell them the truth. I tell them, you choose, probably you will be okay. And most of the people, I never say to the patient, I will fix you. I tell them, you will think about it. You have to keep in mind that in most of the cases, if I don't do anything, you will recover with time, which is the truth. But most of the people who come to see the surgeon, they want to go to the surgery. When you go to see to a garage to see a Ferrari, you want a Ferrari, you don't want something else, you know. So the people come to see you because they want to be fixed. But when you ask to the rheumatologist, they tell you, okay, most of the people, I do not operate on them, and they are happy. On who physiotherapists, they see plenty of people who are recovering with physiotherapy because most of them don't want surgery. If they want to go surgery, and we don't know why, they mostly trust in surgery, they will go to surgery. So it's much more based on the behavior, of the fear of getting older, than based on something else.
Thank you very much. We are really little bit late. Thank you very much, and let's go ahead with the program.